welcome to this discussion, and I think I'll start off by some introduction. So my name's Richard Williams, and I'm a senior lecturer in the social work team at Bournemouth University.
My name's Kathryn Brennan, and I have just finished my Masters at Bournemouth University, and I'm currently about to start my ASYE in BCP Child Health and Disability Service.
Hello, my name's Pru Caldwell McGee. I'm a team manager for Dorset's Children Who Are Disabled service.
Right, thank you both. In this discussion, I'm going to be relatively quiet, but I will certainly start off by applauding Kathy for undertaking a really outstanding service improvement project, and one that's worthy of presenting to an external audience, which we're doing via the website on the university. And really, Kathy, you found an area of passion, of interest of you, and how your ideas can be incorporated into practice and bring a significant gain for minimum cost, if that makes sense. And I think I really want to stop my discussion of this and let you begin, and perhaps and engage with Pru, and to put some meat on the bones, and hopefully people will already have seen your presentation on the PowerPoint, your audio presentation. So Kathy, I'm going to hand over to you.
Okie dokie. Well, just to start with, my background is as a foster carer. So I first came across FASD in that role probably 10, 12 years ago. And that really ignited my interest, I think, because it was on that course that I realised a childhood friend of mine actually was a textbook example of FASD. Now, he had probably the misfortune of being born in the early 70s before it was really known. So he was always categorised as premature and a little bit slow, but with hindsight he had FASD and he was adopted, so that has always been behind my area of interest. And eventually, about 8 years ago, I went into the local authority, and for the last 5 years I was in the assessment service. Now, we didn't see very much of FASD, although so many of our referrals are linked with alcohol, either directly or indirectly. And I think in practice, I always thought, well, maybe they went to the Child Health and Disability Service and it was out there, but it just wasn't being seen by me. And it was only at my last placement that I went to the Child Health and Disability team where I'm now working. And funnily enough, it wasn't over that side of the fence either. So I was like, well, hold on a minute, where are all of these young people going? And the answer was, well, nowhere. We don't really have a way of teasing out and identifying those that are specifically at risk, except for in the 5 years of my career in the assessment, I've only encountered fetal alcohol spectrum disorders twice, and both were in respect of placement breakdowns concerning young people who had been adopted previously. So that is why I sort of really sought for a way of trying to incorporate FASD into all assessments in mainstream and in child health and disability and in reviews. I was looking for a very, very simple way of incorporating that knowledge into every single assessment, which is how I started the conversation with Pru. And I think the reason why that was so important to me was I had on the service improvement project a consultation before, but prior to that consultation I had to write a couple of 100 words and outline the project I was proposing, and we then discussed that. My second appointment was with Pru, and what I consciously made the decision of doing was not doing a write-up before and introducing my project, because what I didn't want to do was really to start the conversation at a certain point. I wanted to really strip everything back to basics and have a conversation about the essence of what I was trying to achieve and where I had taken it in incremental steps. And I think for me, that was a real turning point for the development of my project, because I think at the time Pru asked some very, very challenging and very, very relevant questions. But by the end of our discussion, as uncomfortable as that was for me at the time, I think it was really great for me for you to come to a point where you're saying, no, I get it, I understand, I completely. Why are we not doing this already? So I think during that conversation, you'd come full circle. So
absolutely. What we were talking about in terms of that, it's not a huge change to start incorporating, to get practitioners to really start thinking early on whether there is a risk there of that disorder. You would stand back as a practitioner and say, yes, but we would do that in an assessment. But I think it's fair to say that there are many, many disorders that it's very easy to lose sight of considering that in it, and that's just the natural way that we practice. You look at the home environment, you look at the parenting there and then, rather than, well, actually, what was going on pre-birth, what was going on in the pregnancy. And I think that that's where I came full circle, because it will, I think, help practitioners to really consider in much more depth what the pregnancy was like and what was going on for the family and what was going on for the mum in pregnancy. And I think that that was the key part for me, rather than what's going on in the here and now, which is what assessments do. We work with many families where the children do have learning disabilities, and whether that is that thoroughly explored, or whether there is missed opportunity early on to see whether there is that link. It's really about bringing in that there are other possibilities that we really need to be thinking about here, because then the earlier that it's even thought about, you can then start building that story and actually building the services. Because, as you say, at the moment, very rare that we will see a referral from a health practitioner where it says that the child's difficulties are FASD. So that's where I think it's absolutely crucial. And as you say, you know, the stats speak for themselves. There are many children who are affected by this, but it's not labelled, it's not recognised.
And I think a lot of that is because one of the papers that I looked at, it was a Salford paper by Gilbert. It looked at the experiences of social workers encountering FASD in practice. And there was a real big polarization, roughly a 50-50 split. Some practitioners sort of like knew what FASD was, but didn't know much more than, you know, it was alcohol use in pregnancies. Others had a really good, thorough knowledge of FASD, but that seems to have been acquired via personal interest. And I think that is really problematic, because there isn't necessarily pathways to refer to. So we almost get stuck in this, well, it might as well be labelled as something else. However, I was fortunate enough, Pru, after I spoke to you, to write an email to Professor Mukherjee at Surrey and Borders, and lo and behold, to my surprise, he actually granted me a Teams call, and I had a fantastic opportunity and a great conversation with him, talking about the new NICE guidelines that are FAS specific that have come in. Now, we weren't sure how long they'll take to filter through, because normally he was telling me they can take up to about 5 years. So we're not sure with COVID whether that's going to elongate that or whether it will actually reduce it. But there are pathways. And during that discussion, I said, you know, if I had a magic wand in terms of a social work response, what can we actually start doing? And his reply was, start sticking in flags in things as we see them. So for an example, you know, when we observe that alcohol has featured, not just banned it as teratogens, is actually specify that it's alcohol. So when ultimately the health pathways catch up, we're actually ready to catch up for these children as well. And I think that's going to be really important to us, because as we were talking about earlier, there is an awful lot that is misdiagnosed as it or labeled as ADHD, and as we know, there's no clear link between ADHD and IQ, and yet FASD is the largest known cause of intellectual disability. So we're sort of like stuck in this unproductive cycle, aren't we?
And I think that's the real challenge, as you say, for practitioners, and it's about increasing confidence to respectfully challenge. And that sounds quite wordy and technical, but for me, that is what needs to happen. You know, particularly with learning disabilities, we are absolutely led by those experts in health to do those diagnoses, and to, you know, prescribe and to guide and to do behavioural support plans, for example, and all of that where you might have challenging behaviour. So I think it is absolutely about bringing it into our standard practice language, as you would speak about neglect, you know, or any form of abuse. I think it needs to be part of that standard language, because then we'll increase practitioners' confidence to perhaps question, probe our health colleagues a little bit more if there's missing information, making sure that those, you know, that all of the dots are joined up early enough. That's what it is for me. And this is where I think, you know, your program design is so clever, because it's about capturing that really early, so right at the point of assessment or referral, you're really considering that at the beginning, rather than if you get with some young people, they get many years down the line, and then you're lucky if you just get a learning disability diagnosis, but then you're kind of missing all of that chronology about, was there another reason that was going on? Was there something else that was happening that was environmental, that was contributing to that disability? And that for me is, that's where we need the practitioner confidence to ask those questions, to probe, and perhaps get some tools developed out of it as well. I think would be absolutely fantastic.
There's an educational element as well, because even if it doesn't feature, we need to be having these discussions. We need to be taking some of the shame and the stigma, and we need to be normalizing. And it's this kind of naive view of FASD being preventable. Well, is it really in a population where approximately 70% of women of childbearing age drink alcohol and 50% of pregnancies unplanned? That really does oversimplify it. So there needs to be the educational element as well as exploring the family. And I think it was really important to me that anything that I didn't add to practitioners' workload. It's not about working harder. For me, it's really about working smarter, and what gets measured gets done. It's just a little tweak and not a massive change, but it just really changes your mindset. And I think the pre-birth genogram really sort of gets underneath the skin, doesn't it, and understand what's going on for every single child, not just the family, what was going on in that family at the time that child was conceived or prior to conception, because the narrative in terms of FAS may be very, very different throughout the family.
I totally agree, and I think that absolutely, as you're saying, it is one of those uncomfortable subjects, and I think that even you could strip that back and sort of say, even now, a lot of practitioners, a lot of partner agency colleagues are very uncomfortable talking about sexual abuse. So it's similar in that way, because actually that it's really uncomfortable. It's almost pointing fingers at families, and we must get over that. We must be able to freely speak about concerns, and it's about coming alongside, as we constantly say, and it's understanding what was going on. And that's why I think that your genogram is such an it's not an intrusive way to do that, because actually it's part of your standard. We're coming in, we're doing an assessment. This is the basic information I really need to know to help inform my assessment. So it's not that you're going in with I've got to exclude fetal alcohol syndrome. I think it is, and that's where that education and that building confidence, that it's a perfectly reasonable conversation to have. If they went to the GP would say, how many units of alcohol are you drinking? That's a perfectly routine question to be asked. But I think a lot of the the community-based colleagues, it is one of those uncomfortable subjects. So I absolutely agree with you. It's about demystifying that. It is a conversation that needs to be had, and a genogram, it's just a routine part of understanding what was going on for that child in utero.
And for me, I think it's about changing the lens of how alcohol is viewed within children's social care, and how it's considered as a risk factor, not just a risk to the children that are in the here and now. And if parents are using or misusing alcohol, it really is stripping it back and saying, well, how has alcohol featured throughout this family?
Yeah. And we know history, relationship with alcohol, like with any substances, there is, you can usually see a pattern, and that helps inform assessment. That helps us design how we're going to support that family, how we're going to make that child safer. But the key part as well for you is, your program is, it's identifying actually service design, because what that's then going to drive, if we got more information, it will then create those increased demand in those pathways that we really need to start seeing.
Look, I'm going to just do a quick few words as a kind of a summary, and bring a few points together, if I may, because for colleagues who are watching this now, if you haven't seen Kathy's presentation, then please, I encourage you to do so. Pru's made many mentions of the genogram and the simplicity of it, and Kathy demonstrates this really clearly and extremely well in her presentation. So I encourage you to look at that and to get a full understanding of that. I mean, there are certain issues which you've picked up on, which I think are so huge, really. I mean, we're talking about learning difficulties that we talked earlier about. You're with young people of age 12 who are still waiting. You're talking about people who are being offered diagnoses, so that will just help you get some funding or get you some provision. We talk about the numbers of people that are coming into through referral where there have been issues of alcohol, but somehow FASD is being missed. But as you've identified from your conversations with Professor Mukherjee, NICE coming on board, there is movement to bring a clearer focus in terms of practice. But I think one of the other issues for me that stands out is we talk about some of the interprofessional elements. So these are difficult conversations. Now, social workers are, I like to think, I genuinely believe actually, are trained and are the most comfortable of groups to deal with that context, difficult conversations, that professional curiosity, professional challenge, as you described it as well, Pru. But we're really talking about health visitors as well. We're talking about midwives, and I think perhaps it's a separate conversation, but it's an essential conversation in terms of where perhaps we could share this conversation, this presentation, some of this education, the educational element that you described, Kathy, with professional groups for whom this is equally as important. And certainly for you as a team manager, Pru, to be able to have that early information, to have that recorded so that you're aware of that. Really, you're part of, well, I don't need to do that part of the assessment, or your part of that assessment is additional to what's already known. And I think that's probably something that I could perhaps take forward just from my own in terms of my own context in the faculty, which includes midwives and other health professionals. So that would be a really interesting conversation to see how that goes. But I think in that context, I mean, Kathy has on her presentation, she's included her contact details. So obviously do make contact with Kathy directly. And it will be interesting to hear from colleagues who do listen to this discussion or who do look at the presentation. And as Pru, and as you did when you were listening and discussing with Kathy earlier this year, when you got it. Oh yes, of course. It's actually quite simple. And not only is it simple, it matters. It makes a difference, and it's a tweak. It's not a cost. It's not a cost in terms of money. It's not a cost in terms of time, which is also money. It's just, this is really simple. We can do this. So I encourage anybody who's reading or looking at this to consider that in their own practice.